Rob, Ed, we can begin.
And feel free to start.
Thank you, Rob. Well, welcome everybody to the Member Position Advisory, where we're going to be focused on prior authorization today, which is part of the proposed interoperability prior authorization rule. Our agenda today will just outline the NPA process for those who are not familiar with it. We promise to go quick on that. Then we're going to go ahead and get into some details on the proposed rule. We have Derwin, Stanley, and Bob and Rob helping me take you through the different discussions. We have all sorts of slides that we'll be presenting that will inspire conversation. And then we'll have a wrap up at the end with Rob and I. Promise to be very interactive, encourage you to participate today. And I'll give you a pep talk in a moment. Next slide, please. So many of you have seen these sorts of slides before, but just in case you haven't, you are in a very important spot. We have the ability to make comments to Health and Human Services, taking all of our WEDI membership together to be able to provide feedback into Health and Human Services, in this case, CMS. We're formed in 1991, 32 years ago, inspired by Dr. Lewis Sullivan, who helped create us. We are named in the HIPAA legislation as an advisor to the Secretary of Health and Human Services. And really, we value our relationship with CMS, Office of Civil Rights, and also ONC to provide a nice working relationship where we interact together and we help those organizations, among others, like CMS Innovation. Want to let you know we have I see at least one CMS person. One of my favorite ones, Lorraine, is on today, and I know she was on the last call too, where CMS does listen to us while we have these calls. So we really value Lorraine, your attendance. Want to make sure you understand we are a unique group of folks, right? We're health plans, providers, vendors, software development organizations. We have state and federal government representation, some really cool associations that are involved with us. We're also linked out to other organizations as well. And we work together and hopefully have that one voice that we can share with Health and Human Services together. I encourage you while you're attending today, think about your organization and your perspectives on these different rules, but also think about the patient because we're trying to better healthcare together, and there's no organization like WEDI that does it as good as we. At least that's my opinion. We have 18 different work groups and task groups. We also have a bunch of educational activities. Encourage you to get involved in those. And our role is to convene, collaborate, educate, influence, and advise together. Next slide, please. Oh, and your feedback matters. Part of the MPA process, the Member Position Advisory process, which we'll be talking about in a moment, is about trying to survey first, to be able to understand your perspectives ahead of time and presenting some of those survey results during the NPA process, and also just to gather your feedback so we can help form our comment letters. And so I want you to be encouraged to go ahead and complete that industry survey on prior authorization attachments proposed rule. By the way, I believe Thursdays are NPA for attachments. That it promises to be very exciting as well. Next slide. And the NPA process was actually influenced by our WEDI policy committee that was chaired by Bob Bowman and Jay Eisenstock, with a lot of guidance from our past chair, Nancy Spector. The old process was the PAG, or Policy Advisory Group, which was very formal, in person, one card for every company that would raise your hands to vote on very specific topics. We've learned an awful lot from virtual meetings. We can stand up those virtual meetings quicker. We can invite lots of discussion. We've been able to tease out some very interesting perspectives. And so they developed the the member physician advisory process, or if you're cool, you say MPA, that will be able to solicit all sorts of input from you. And it's not just for proposed rules. We can do it for other topical issues, any kind of proposals that are going on in the public or private sector as well. Again, we have done a survey that to be able to help prep for this particular meeting as well as others. We've also done some interviews and face-to-face, and we'll use that to as Rob will guide us through the different decks, the different deck questions. Also want to let you know the MPA process was approved by the WEDI Board of Directors, which represents you. I think a very important part is that your comments today are recorded, actually listened live by CMS, but also will be fundamentally important to generate our comments to Health and Human Services. So if you do differ today, if you disagree, that's awesome. We can go ahead and make comments about that. So we have a group of people that feel one way versus another. That's actually great information for Health and Human Services. So we encourage you to participate. And so please, again, raise your hand. We'll take you off mute and you'll be able to comment. And Rob, to you.
Thank you, Ed, and let me add my welcome. Next slide, please. I just want to also thank our facilitators for today. We are really delighted to have some of the leading industry experts on these issues join us to help move the discussion along. So this event is triggered by the publication of the Notice of Proposed Rulemaking from CMS. I won't read the whole thing, but the most important thing for us is the improving prior authorization processes component of the proposed rule. That's what we'll focus on today. We did talk about the interoperability components last week. So comments are due to the agency by March 13th. Of course, we don't have any timeline in terms of when the government could release a final rule on this. But of course, as always, we'll keep you informed. Next slide. As Ed said, if you've got a comment, you've got two opportunities to share it. One is through the chat. And just know that we capture the chat. So if you wanted to make a longer comment, we do capture that and we can include it in our deliberations at the end as well. You can raise your hand. We encourage you to share your thoughts. Of course, keep your comments succinct, and we'll be sharing the slides and recording after the event via email. Next slide. So let's talk about the vision of CMS. And there isn't anybody on this call who doesn't understand the challenges associated with the prior authorization process on both sides. It's certainly a burden for providers. It's also a burden for health plans, and it can actually impact patient care. So CMS has been working for many years within that agency, but also working with groups like ONC, the Austin National Coordinator for HIT, on the issue of prior authorization. They've done listening sessions. They've listened to the industry, including WEDI. And so it is culminated in this proposed rule. So if you go to the next slide, I'll just say that, as I said here, as I said earlier, CMS says HHS has been studying the PA processes and their associated burden for several years. So they understand what some of the challenges are. And they understand that a lot of the time currently information is exchanged between health plans and providers via fax, telephone, and web portals. And there are considerable and unpredictable wait times to receive the final decision from the health plan. Next slide. And so they state in the rule to improve the patient experience and access of care. We are proposing several new requirements for prior authorization processes that we believe would ultimately reduce burden for all these stakeholders. And so we're going to talk a lot about fast healthcare interoperability resources, or FHIR, and the PARD, or the prior authorization requirements, documentation, and decision API. That's a central part of what CMS is proposing. And again, they argue that the API would streamline the prior authorization process by automating the process to determine whether a PA is required for an item or service, therefore eliminating one of the major pain points of the existing process. So they clearly have taken a lot of time. They've worked with various agencies, and they have come up with a proposal. Many of you know that CMS did release a proposed rule back in December 2020. That had a very short turnaround time, and a tip of the hat to Nancy Spector, who led WEDI's efforts over the December holidays to craft a well thought out response to that rule. They took, I believe, somewhere around a week and a half to digest all of the comments, and they released a final rule in January 2020, just before the new administration took office. That administration, the Biden administration, put that regulation on hold. It pulled it out of the Federal Register, and so they have reissued that proposed rule with some carryovers from the 2020 rule, but also some important modifications, not least of all the inclusion of Medicare Advantage plans in the impacted payers for this rule. So yes, there are some similarities with the 2020 rule, but there are also some enhancements as well. So next slide. Oh, sorry. Yeah, sorry, go back one. Yeah, so what we're going to do today is we're going to be discussing a number of the key issues, but we're also going to ask you to complete some polls. It helps us, we capture the poll information, so I'd encourage you to please answer the poll when it comes up, and we'll try to keep it up on the screen for a few seconds to allow you to see the results. So with that, I think we'll go to our first poll, and that's a simple one. We just want to kind of gauge the audience a little bit. So please rate your level of knowledge with the improving prior authorization processes issues outlined by CMS in the NPRM. So not surprisingly, it looks like we have a very knowledgeable audience today. Most of the folks either very, somewhat, or slightly. So it looks like we've got a good group with us. Leave it open just one more second. All right. Okay, Michael, I think we can. So it looks like, again, we've got most of the folks saying very or somewhat knowledgeable with the rule. And as Ed said, this is your opportunity to share your organization's perspective on these important issues. So please feel free to write in the chat or raise your hand, and we will unmute you. So with that, we'll close this, go to the next slide. And we do have, we've set aside 3 hours. I'm not sure we'll use all 3 hours, but it's important that we have enough time to properly go through all of these issues. And the first one that they talk about is they name 2026 as the implementation date, which is interesting in the sense that they've picked a date, but of course they've not picked a date for the release of the final rule. So I want to open it up first to our facilitators. Is that an issue. The fact that they say the industry will have 3 years, but of course, the clock started at the release date of the proposed rule, not of the final rule. So I don't know if any of the facilitators, Stanley, if you have some thoughts on this.
Sure. Thank you very much, Robin. This is a little bit different than most of the other requirements under our HIPAA and similar rules, where it was always a number of months or years after publication and the effective date of the final rule. It seems that January 1st was sort of just a random date that they picked, but clearly it's no longer 3 years from now. And if CMS and the industry believe that 3 years is a fair amount of time, then in my opinion, they ought to say 3 years after the effective date of the final rule. But of course, there are a number of questions. Is 3 years a fair amount of time? And what about all of the other requirements that are now under consideration in proposed rules or in other discussions, like upgrades to the X12 standards, for example? And should these kinds of changes be coordinated with those changes? So I think there's a lot of issues there. You have a question about the stakeholders start implementing prior to the publication of a final rule. In most instances, stakeholders do not implement prior to the publication of a final rule. Generally, the industry tends to wait till the final publication and an implementation date is set before they begin their implementation process. They may be finished before the end date of the final rule, but there's a tendency to wait for the final requirements before beginning their significant planning and implementation. So there's a couple of questions that need to be considered here.
Yeah, and as you alluded to, Stanley, it seems to be a departure from previous rules where it is a delineated 24-month period following the effective date. Ed?
Yeah, thanks, Rob. I would say a couple of things. I remember back in Stanley's time when we have a 2-year rule, everybody was always pushing them to make it 3. This time they actually gave us 3 years, and some folks say, gosh, that's a long time till 2026. But I think there's some things baked into this that make it really interesting. So, having health plans digitize their medical policies is going to be quite a lift. And that would be, to me, the long arm on whether we can accomplish this or not and how hard that is. Also, it's interesting they didn't mandate the different API implementation guides. I think that would really help everybody get together better. And giving 3 years to be able to really get those IGs right, I would think that gives us enough time to mandate that. So those would be some thoughts I'll be passing up coming here soon.
Yeah, I'll just say that Diana raises a good point that you don't want to get started implementing a proposed rule because the final rule could have significant differences in it. You don't want to spend money on something only to have to change that. And candidly, this is not an easy regulation, and potentially the agency might have more time than even a year to finalize the rule, which would make it even less than 2 years to implement. So I think a lot of interesting points here. Stanley?
I'd also say that because we've got a variety of proposals, there may be an opportunity to split implementation dates around certain proposals for the APIs, another date for the 7-day requirement and things like that. I don't necessarily think that every one of the provisions of this rule needs to be implemented at the same time.
A good point. And also Chuck has mentioned that there's a lot of discussion in the industry about should it be a January 1 start date when everything starts on January 1, or should we be looking for perhaps a mid-year start so not everything is piled on at the same time? WEDI did make that suggestion to the NCBHS when we were discussing the implementation or potential implementation of some of the 80/20 transactions and CAQH core operating rules. Thank you, Chuck. Very good point. So I think if we don't see it, any other hands, I think we'll go to the next slide. It's a poll, and we're interested to get your opinion on the implementation date. So should it be 2 years from the effective date? Should it be as they say now, 26, or 3 years from the implementation, sorry, from the effective date, or 4 years from the effective date? So a few are saying yes, just continue to implement the proposal, which is January 1, 2026. And it looks like the most support, as we're seeing here, is for 3 years from the effective date. Very interesting. The one thing that we have learned from past experience is no matter what the date is, we'll always ask for extensions. But so that's something to consider. So we do have a little bit of a split. With that, I think, Michael, I think we can close that and go to the next slide. Okay, so I thought I would ask Bob to walk through the PARD process, the APIs, and talk a little about what the rule is proposing.
Okay, Rob, thank you for inviting me to help facilitate this. The rule is proposing, and it names as proposed implementation guides, the work that Da Vinci's been doing for roughly the last 5 years, to allow a provider in clinical workflow to go and send a request electronically to a payer, indicating what is planned to be done, an order, scheduling an appointment, a discharge, whatever it happens to be, and allow the payer to come back and indicate whether there is something that needs to be done as far as documentation, as far as prior authorization, as far as meaningful use for that particular item or service. It also allows the payer at that time to indicate whether or not there is additional documentation that may be required. Because the way the implementation guides are written, they have the ability to access the patient's record through a token provided by the provider so that they can determine whether the documentation already exists or whether additional documentation is required. So now in real time, in clinical workflow, there's the possibility of getting the answer. Do I need to do prior authorization? We'll just focus on that. And if so, do I need to go and provide additional documentation above and beyond what I already have? This simplifies the ability to go and handle prior authorizations, and hopefully over time brings it all the way up front in the clinical workflow so that by the time the patient's ready to leave the practice, approval's already been given, and it's potentially possible to schedule an appointment with whatever comes next. The third guide is prior authorization support, which automates the ability to submit a request, and we'll talk about this a little bit later, to the payer that is converted into and out of the HIPAA mandated 278 transaction. So these are all the various pieces that underlie the very general comment of an API. CMS has only required, not proposed, required support for things that are already part of the 21st Century Cures Act. So these are things that are being implemented by basically all of the covered entities in the industry.
Bob, can you explain a little about the implementation guides and what they require? Because we had some really good discussion on our prior auth work group call recently about there was a comment in the chat about the 22nd rule. If you could just comment briefly about sort of the data flow between the payer and the provider in terms of timing?
There's actually, and the guide is not published yet, so we're still in the process of settling on certain items like how much time there is to respond. But the intent is to provide the response quick enough, and there's a possibility of having it pinned. Okay, not pinned, but say we can't give you a decision right now. And this is not prior authorization. We're not solving it. We're just indicating whether or not. Okay, let me back up. 3 guides: coverage requirements discovery, where we ask the question, is prior authorization necessary? The expectation there is the response will come back and say in time that it will not impact clinical workflow. That's probably under 10 seconds. The next step is to gather the data, the information, the documentation. That's not a real-time process. That's something that you can interact with. Pull data from the record, may query the provider, may be done in the back office. That's not a timed process. And the third one is the submission of the prior authorization request. And that has a 15-second response time requirement, meaning within 15 seconds of submitting the prior authorization request, the payer needs to respond with either an affirmative, a denial, or a pinned, so that the provider understands where things are in the workflow process. Is that what you were interested in?
Yeah, very helpful. I think we can go to the next slide, Michael, if you don't mind. So here's the list of the guides that Bob was discussing. And one of the things that we've been talking about, not just with this rule, but also with the electronic transactions, is what implementation guide should be adopted. And there's some argument about if you name one that's ready now, but it could be obsolete by the time the final rule comes out. I don't know, Bob, if you got some thoughts or other facilitators on what WEDI should recommend to CMS in regards to the implementation guides.
HL7 and DaVinci are in the process of publishing the next version of each one of these guides. Those versions provide significant additional capabilities for both the payers and the providers, as well as support for the patient in getting answers. We would recommend that when they come out with the final rule, they name the next version of the guide that'll be published over the next several months for each of the 3 guides. There's a strong argument in making them recommended at this point rather than required, and the strong argument is the following. As they are implemented, we will get feedback, and that feedback will require release of another version. So rather than fix it to a specific version at this point in time, it may make sense to turn around, make sure we've gone through any feedback we get that does require significant update or update to these guides, and then name the guide into regulation in the future. There's been some argument that maybe this should be done through ONC and not through CMS, because ONC has a process called SVAP, Standards Version Advancement Process, that they can use to name new versions of an implementation guide or a standard in a sub-regulatory fashion, so that we don't become constrained like we have been, for example, under HIPAA, where once something is named, that's it until a new regulation comes out.
Great points. We've got Janice.
Hi, this is Janice Karen from the Massachusetts Health Data Consortium. I find this conversation pretty interesting. We as a group are very strongly in favor of specifying implementation guides, and the feedback that we've gotten in terms of why they're being recommended versus required is actually the exact opposite of what you're talking about, which is that the versioning isn't clear and there isn't a specific version they can point to. I have pushed back that all of the implementation guides are versioned and that isn't true, but that's really what we've been hearing. So I don't know if anyone has any comment about this sort of almost diametrically opposed rationales for the same thing, but I find it really interesting.
May I respond to that one?
Sure. Go ahead.
Yes, all of the guides have versions. That's a statement of fact. Once they have been published, they have a fixed version. The issue is the guides that make sense to name are in process of being finalized and published. And to the extent during implementation, we find the need for a new version to support something that may have been missed or something that would provide additional capability that the industry needs. We'd like not to fix them in a regulation, which would require a new regulation to come out and potentially several years to wait before you can take advantage of something that becomes part of another version of the guide. That's the reason for the recommended, not the fact that there isn't a version.
Let's turn to Derwin, and then we'll go back to Janice.
Yeah, hi, everyone. I was just going to bring up something that Stanley mentioned earlier when we were talking about the implementation dates, and that this, I don't know if anybody's been talking about this, but this may be an opportunity here to have different dates for implementation. That the first part that Bob was describing, where the provider requests the information from the payer, the CRD part could be implemented first, and then the response that goes back, the DTR could be second, and then the prior auth part could be third. If that has been thought about by anybody.
Yeah, no, in fact, they discussed it in the proposed rule, Derwin. I think a great point. And I think we have a slide on it a little bit later, because I think that phasing in approach potentially is an important one to discuss here. We'll go Janice and then Stanley.
Hi, yes, Janice again. I just want to point out, although I'm not a big fan of the SVAP process, because I feel like there's not enough requirement for backwards compatibility and things. And I understand that SVAP tries to account for that, but it's still a little bit hairy. But CMS explicitly said in this particular rule that they are effectively leveraging the SVAP process for implementation guides. So I guess I'm a little bit confused as to why needing to change the version of the guide would be an impediment to specifying a guide under those circumstances. And I apologize for harping on this, but I feel like this is a really key point.
Thank you.
You mind if I respond?
Oh, please, go ahead.
The SVAP process is something that is available to ONC, not directly to CMS. These guides would have to be named by ONC as guides that are supported for example, ONC's certification process to be subject to SVAP. Where they support SVAP right now is in things like US Core. They support ONC's SVAP process. In OpenID, they support ONC's SVAP process. CMS by itself doesn't have a SVAP process that it can count on.
Excellent. We'll go Stanley and then Diana. I think you're on mute, Stanley.
There we go.
Good.
Yeah, this continuing conflict between the burden of updating and sticking with a quote older standard. It's something that we just have not been able to resolve. I don't know what the burden on vendors and providers and plans would be in the continual upgrading of these fire IGs, for example, and that's a return on investment or cost and benefit argument that needs to be looked at. It is hard for a vendor to say, all right, I'm going to support this version and implement it, and then 6 months later have to support a new version for some people and not for some other people, the whole purpose of the standardization. So I think the cost of upgrading will be will be something that needs to be considered if we stick with a single version or allow for multiple upgrades throughout the SVAP or a different process.
Well, to be clear, SVAP is only executed once a year. It's not 6 months. And the time frame to voluntarily adopt a standard that has been adopted under SVAP is unrestricted. So the requirement's still the floor. The ability is to adopt a new version that has additional functionality, but that's a voluntary process. So we have to be clear as to what they're capable of doing. It would be like allowing you to adopt another version of X12, but not requiring it. And so if two trading partners wish to do it, they could. Right now, they can't.
We're going to go to Diana and then have a couple of closing comments.
Hello, yes, this is Diana from State of Michigan Medicaid. The reason I am really hesitant with the versions is it's great that you only expect, if you want to update your version, to do it once a year. That's a big help. Thank you. But what I'm expecting is you say that that's the floor. But then if two trading partners want to voluntarily like update to the next version, that is requiring vendors and payers to be able to hold multiple versions of the same IG to run their systems. And then when you start looking at, okay, you have to respond. I shouldn't say respond because we're talking implementation guides, not X12. But then if you have to be careful, because if somebody sends you, okay, in version 1, you have to be able to respond in version 1, but somewhere else, if they send you version 2, you have to respond in version 2. Like, I forget the lady's name who spoke earlier about backwards compatibility, because if somebody is sending you version 1, you might not be able to respond in version 2. Their system might not be able to accept it, read it, understand it, or get the extra data you're sending back that they did not ask for. I actually think it is better to stay with one version on the floor as a minimum. I really think multiple versions are a bad idea. I think it's going to cause too much money for vendors, clearinghouses, and payers. And if you have a floor, you think some of these providers, all they're going to do is the mandate. They're going to be the lowest. They're going to take the lowest, the least amount. Great. They're not going to want to update every year. But then you've got the people who make the big money, the companies, the clearinghouses, like, yes, we want to be on the cutting edge. Yes, we want to be on the bleeding edge. Sorry, Chuck. And they're going to spend that money. But then you're putting all of the money, the time, the pressure, the maintenance on the go-betweens, okay, between the provider and getting paid. So your clearinghouses, the vendors, the APIs, the payers. And it's a lot to put all that in the middle on just a certain stakeholders.
So let me be clear. CMS has made it clear in their regulation that anything adopted under the SVAP process has to be backward compatible and may not require somebody using a prior version to upgrade. So I think they're trying to cover that. I'm not saying we're perfectly successful at this point, but that is at least their stated intent.
This has been a really interesting discussion. A couple of things jump out at me. One is that a lot of this, the version issue impacts ONC EHR certification as well. So if they're slow in recertifying, then that could impact the versions as well. And Bob, if I'm hearing you correctly, one of the arguments against naming a version is that we don't want to be locked in like we have with 5010 for 10 years with one version when there's a better one or several that have been developed. So the answer for WEDI may be that we need to not only potentially name a version, but also have a faster process of updating those versions. Is that a fair sort of compromise here?
I would suggest that, given that the version we want named is the one that's going to be published over the next several months for each of these guides, that is the version that, now I still understand why they're doing recommended, and that's because they don't have the ability to go in. If they name a version, meaning CMS itself names a version, that's no different than any other federal regulation, except for ONC. That'll be the version that you're stuck with. And that means new functionality. For example, the ability to support social determinants of health, or some of the things we're doing. Health equity will not be available at all until a new reg comes out. So those are things that we're trying to avoid, is being so tied to a specific version that we can't adopt new functionality, not break old, but adopt new.
Okay. I think with that, I think we can go to our poll slide, our next slide. And we have a poll on this. Because it is an issue. Do we recommend or do we mandate the IG? I think we've heard sort of both sides. We're interested to hear what you all have to say. It looks like. Okay, so Bob responded to Chuck that we expect the new IG to be out in the next several months. So it looks like the majority are saying mandate. Again, I think the caveat here is there has to be a faster process of updating IG versions. I think that's something that we can include in our comment letter as well. And again, if you're not voting in these, please do. It's important. We capture all the data. And so please share your thoughts here as well. All right, so it looks like about 60 to 30%, with 8% saying unsure. Okay, thank you, Michael. I think we can go to the next slide. So we did talk about this last week a little bit about that the agency has excluded drugs for the most part, but we also talked about that, and they mentioned that NCPDP rules handle the drug side, but we did identify that there might be a gap between what's covered under NCPDP rules and drugs that could potentially be covered by PARD. So I don't know if any of our facilitators want to comment on this. Ed, you always have a comment, so maybe I'll turn to you first.
Rob, you always call on me. I promise. Sometimes I'll say something smart. Sometimes I'll say something not so right, but I'll always answer you. I personally, I would like to hear what that gap is before commenting. It's my understanding that it was called out that NCPDP in the proposed rule did have this function, and and also thinking through some of the medical policies that have to be digitized, and to be able to add that to the list on drugs, I think that would also add a burden. But I'd like to call on those who may know that specifically.
Yeah. I don't know, Derwin, if you've got any thought. Okay, we got a question here. Marianne?
Hi. Yeah, so I could speak to some of the drugs that aren't NCPDP drugs. They're billed under the Medicare Part B. So there's 34 home infusion drugs that we have to, will they be included? That I don't know. How are they included? Right now they have Medicare guidelines to how they are covered, but will they ever require a prior authorization in that sense? I don't know. So that's why I think that taking a blanket statement that it doesn't apply to drugs, what about those drugs that are covered medically? Yeah,
I think that's exactly the gap that we were exploring last week. I don't know if we have any providers on the line that want to comment on whether or not we should at least maybe suggest to CMS to look at this gap to see if there's any drugs that need to be pushed over. Celine? Yeah, Celine from the AMA.
Yeah, hi, Rob. Yeah, so excluding all drugs from the provisions of this NPRM definitely leaves a sizable gap. Excuse me. Currently, the 278 is what covers the medical benefit, and we understand that this is a complex area, but we urge CMS to do further research on this issue, engage with EHR vendors and NCPDP as well as HL7, because we don't know the appropriate PA automation for the solution for drugs, but definitely as written, there's a sizable gap, including infusions related to chemotherapy and things that do require prior auth at times. 99% of Medicare Advantage enrollees have Part B drugs in their plans. And, so we're very concerned about this, and it's definitely something that we hope WEDI will comment on.
Excellent. Yeah, and Bob mentions in the chat specialty drugs under the medical benefit and those that are associated with durable medical equipment. So yeah, very good. I think it's absolutely a good point for WEDI to raise. Not saying we have a definitive answer, but it's something that CMS should explore further. So very helpful. All right, Janice?
Hi, yes, this is Janice again. I also wonder, I realize there are existing processes for drugs, for standard drugs, but I also wonder if there's additional burden from requiring it to be done in different ways. And I understand that for some plans, drugs are handled separately, so that may not be the case. This is not my area of expertise, but it is something that I wonder about, and I've discussed with folks about whether having these be two completely divergent processes is appropriate or not.
No, I think it's a great point. And that, I think it might be fair for us to comment to the agency along the lines of this requires additional consideration and input from plans and providers and vendors to make sure the solution meets everybody's needs, in particular the patients. Diana? Yep.
Okay, I hit the unmute. There's a good thing. I said, I think it either should be you either do all drugs or you do no drugs, because every payer is going to have some drugs that are covered under DME. Yes, but not every payer is going to have the same drugs covered under their DME policy. And then we talked about opt-in and opt-out. What if a patient does not want any of their drug information shared? I mean, think about it. If you use drugs, okay, well, if they don't want their psychiatrist, their mental health, they opt out of sharing their mental health claims, right? But you're okay to share the drugs that their mental health provider assigned. I mean, the drugs you're assigned by your mental health provider still is covered under mental health. I mean, it's either all or nothing, and I think patients should be able to opt out.
Yeah, excellent. We've got some good chats as well. Chuck asked, so should drugs be excluded as currently described in the NPRM, except for those mentioned by Bob? Exceptions to the exception. And then Ed writes, this part of the NPA is awesome. Having people that have specific information to share with others is so valuable. Thank you. Bob, you've got a point?
Yeah, I just wanted to make one point that there are some situations like home infusion drugs, which Celine mentioned, where the drug and the device are ordered together. They can't be separated. That's a situation where we're going to have one process that allows you to go and prior auth both the drug and the device.
Excellent point. Diana, you've got your hand up. Is that a leftover, or do you have a new comment?
It's a leftover. I keep forgetting that part. Sorry.
No problem. And Marianne? Michael, if you don't mind unmuting Marianne. There she goes. Good.
Oh, sorry about that. So I think we have to think about, just because the way something is currently covered under Medicare doesn't mean by the time that this is implemented that that's the way it's going to be covered. So I think we have to think broader than, well, today it's covered under a DME piece, so we don't necessarily have to worry about it, or that infusion pump needs to be covered in order to be a part of this. So I think that you have to think broader than that, there are several, when you come to commercial payers, drugs that require prior authorization all the time. Medicare normally does it with, or CMS normally does it more with guidance and rules, whereas your payers do it with prior authorization. So if we want to look at this in a broader sense and how other payers, because normally once Medicare adopts something, other payers will too, then we need to think about in a broader sense, how will they adopt this? And so I think you have to look at it for drugs. You can't just separate them out.
Excellent point. So just thinking about a potential response from WEDI, maybe along the lines of this is an important issue, not just today, but potentially in the future. And so CMS needs to be thinking about not only a policy that works today, but a policy that works as policies in regards to drugs change. So excellent.
Correct.
Point.
And there's so much change in the drug spectrum happening over the next 3 years with, other acts and such like that. Thank you.
Excellent point. Yep. Great points. Stanley?
I think we want to be careful that at the moment this rule applies to a certain set of payers, focusing mainly on Medicare and Medicaid and the exchange plans. So the processes that they have in place today for drug prior authorization are probably what we should be focusing on. The hope, obviously, is that other commercial health plans or commercial lines of business will follow some of these rules that they're not required to under this rule. But we ought to be keeping in mind that Medicaid and Part B and Part D are what we should be focusing on in terms of responses regarding the prescription and drug information.
Yeah, very good point. I will say that we asked that question in our survey, or we asked them about, if you are a commercial payer, will you be supporting this across all lines of business, not just those that are required? And we've got about a 50-50 split. Half are saying yes, they will apply this across all lines of business. The other half saying they're unsure at this point. So good point, Stanley. I think we have to be thinking longer term as well, though, in terms of, can we come up with a policy, or at least suggest that they keep this idea fluid and perhaps think in the future about either guidance or a new rule to cover.
Yeah, and if there are significant differences in the way commercial health plans do this versus what Medicare and Medicaid do, that is a bit of a concern or a conundrum for these requirements.
Yeah, I think as Jana said, I think that the key is to really understand this gap, how big it is, how challenging for providers if it's not filled. And so maybe that would be one of our recommendations to CMS. So great discussion. I think we can go to the next slide, which I think is a poll as well. So we have talked about this. So assuming that they can do it, I guess the question is, should CMS fill the gap and apply this to drugs not covered under NCPDP rules? We're getting majority of folks saying yes, and a number of folks saying they're unsure or have no opinion. So I think it's fair for WEDI, rather than have a blanket statement of saying you must include these drugs, rather phrase it more so as you should explore this issue. I think that would be fair, I think. Celine, thank you for that. Yep. All right. So I think we can close this and move to the next slide. Okay. So this is the prior authorization criteria, where the government says we understand that payers may use different criteria to make PA decisions. And this is really getting at the issue of, we talked about this a little bit last Friday about having each payer may have their own criteria in deciding whether or not to authorize a service or item. And so CMS is asking the question, should we in future rulemaking, should the authorization from a previous payer be honored by the new payer? And if so, should the PA be limited to a certain period of time based on the type of prior authorization or the patient's medical condition? I will note that back in 2018, when providers and payers came together on a consensus statement, that was one of the issues, was continuity between health plans for patients on treatment protocols, where in some cases, patients are required to go back to take a drug perhaps that didn't work before getting authorization to move to the newer drug. But let's open it up for discussion. We'll start with Janice and then go to Diana.
Hi, yes, Janice Karen from MHGC again. Two quick comments here. Most of the federal rules that deal with anything related to continuity of care put a 90-day window where you have to continue with the previous coverage or honor what was there. So I think that to be consistent, that having a 90-day window for that to give some time to do new processing if it's necessary would be appropriate. But I also would add one other comment here. We're in favor of possibly exploring the idea of having some commonly agreed upon or mandated rules for frequent items that need PAs. And if something like that were put in place, then it would be much more of a no-brainer to have a real continuity of care, because in theory, the old payer and the new payer would be using more or less the same rules to make that decision. So I would put those two comments out there.
Excellent. Diana?
Oh, I'm unmuted. Okay. I am a little worried about this because there's a huge difference between commercial and a federal government or a state government plan like Medicaid. I have no problem with if for some reason a patient is still under treatment and has a prior auth, that we would look at that prior auth information. And maybe when we get that 5-year history and we get all those documents that are supposed to come with a prior auth, we'd be able to say yes and continue care, okay? And maybe and get them Michigan Medicaid prior authorization number. But not every payer out there is going to use the same documentation, and due to policies, not every payer's policy is going to match every other payer's policy as what is required and what is not. And for the drug, she goes, well, yes, you tried the drug in the past with your other payer. We're going to make you try it again. I think if you would pull with the next payer would get that information and look at it and say, hey, it didn't work 3 months ago. Why do we think it would work now? Being able to get the patient's previous history would be able to eliminate those repeat steps. I'm not exactly sure about continuing for 90 days because you have the prior auth that says what the new rule coming out says 7 days for standards. You wouldn't need 90 days of coverage.
Gotcha.
I just don't think it's safe. I don't think it's a good idea to say the next payer must accept the previous payer's prior authorization, because you've got government payers out there, and government payers are way different than commercial.
Gotcha. And Celine, see your hand up.
Yeah, hi, Celine from the AMA. I wanted to agree with Janice's 90-day requirement. That would also align with the MA rule that was just published and comments were due last month. And then as for the different payer policies, I think from a provider perspective, it's important to remind everyone that those should be based on clinical guidelines and evidence-based medicine. And so if they're based on that, then they should transition between payers fairly easily. So thank you.
I see Stanley, you've got your hand. Don't forget to unmute.
Very good. Yeah, just did. Again, there's, we keep on talking about commercial payers versus the government payers, and that might be an interesting twist on this. If you're going from Medicare to Medicaid, for example, or Medicaid to Medicare, perhaps that should continue. But if you're going from a commercial health plan to another commercial health plan, you wouldn't be covered by this rule. And if you're going from commercial to Medicare or Medicaid, ostensibly you wouldn't be covered by this rule. So there are questions around that. I don't understand how you can, I wouldn't understand how you would expect a health plan to cover a service that they wouldn't normally cover just because somebody else made the decision that it should be covered if there are different criteria. I know, taking it from the patient perspective, clearly you'd want to continue, but that's an awful lot, I think, to ask of a health plan, particularly in terms of premiums and cost. If they don't have any control over that, how are they supposed to budget if they have to accept somebody else's decision?
Just playing devil's advocate here, Stanley. If potentially it would be perhaps even more expensive for the new health plan if the patient goes off their meds and they have a bad experience and they end up in the ER. It could be more expensive. So one of the questions is, there's the 90-day concept. If it was 30 days, then it would be less of a risk potentially for the health plan. It would give the patient and their provider to, especially to Diana's point, if we have this 7-day turnaround time for the PA, at least it gives them a fairly quick window to get the new drug approved. But let me turn first to Diana to get her point of view on this, and then to Bob.
I'm so sorry. I thought I unmuted, but I was muted. That was a lot of information. Could you repeat that again?
So,
Yeah, go ahead.
So I think we all agree that it's a challenge when the receiving health plans requirements may be very different from the old plan. But if the patient does not continue, for example, their therapy that they've been on for 2 or 3 years, if they have a gap, it could result in an adverse health event, which then they end up in the ER, and the new health plan is required to pay for that care, which is perhaps more expensive than it would have been just to continue the treatment. So if the compromise here is maybe to have a 30-day window, not a 90-day, and then it allows the patient and the provider to go through the faster PA process.
Okay, I could understand that. Let's say you have a job and you're covered under Blue Cross Blue Shield. You lose your job, you can't get a job. So now, okay, I need to apply for Medicaid. And yes, we do have 7 days according to the other rule that's coming out. But if it is like you're out of your mental health drugs, or you're out of certain kind of antibiotic for a condition, I believe we also have urgent. But yes, I think there being an overlap would not be a bad idea. 30 days, I think that would be much more doable than 90. But then the patient has to understand that at that 30 days, just because you have that PA carried over for 30 days does not mean your provider still doesn't have to put in
Yeah.
a new application and get a PA that is applicable to your new health plan payer.
Yep.
I understand there are certain situations where, yes, okay, I lost my job. I did not realize I was going to lose my job and I'm running out of my medication or my treatment like in 3 days. You know what I mean? I can understand that situation. 30 days is probably a lot more reasonable, I would say, than 90.
Yeah, we're hearing it in the chat, more support for the 90. So maybe 60 days is the compromise here. But I think you can certainly see the arguments from both sides. I think at the end of the day, probably the patient's health should be front and center on this one. We're going to go Bob and then Marianne.
Yeah, Daniel made the point I was going to make, that there has to be an assumption that that benefit is actually covered in the new plan. If it's not, then here requiring them to support a prior auth doesn't make a lot of sense. I also agree that 90 days is probably a reasonable amount of time, given what it takes to go and reevaluate the patient, go through whatever approval processes there are. It's not going to happen in 30 days in many cases.
Yep. And I'll just say, Chuck says at the end of the 30 or 90 days, what happens when the new carrier denies the request? We'll go to Marianne and then Daniel.
Hi, can you hear me now?
Yes. Yep.
Good. All right. So that's all good when we're going like from a Medicare Advantage plan to a Medicare Advantage plan. And I think that we also need to think about, how does it happen when patients age into, say, Medicare? So I'm on that Blue Cross Blue Shield. Everything is covered. Let's say, and I just take it from my perspective, an IV antibiotic, and then I age into Medicare, that IV antibiotic is no longer covered for Medicare. So if there was a prior authorization through the commercial plan, what would you do? You can't make Medicare cover something that they statutorily exclude.
Yep. No, exactly.
And I think that's where, just to jump in, I think that's basically what I was going to say is you can't change benefit plans as part of this. You cannot mandate that some payer cover something for a patient that they don't cover for any of their other patients just because of this. But if it's covered benefit to covered benefit, which I think would take a lot of the commercial Medicare Medicaid changes into account in terms of, if it's still covered under their benefit plan, then I think the rest of the prior authorization, is it at an outpatient rehab, is it at an outpatient surgical center, all that stuff, like whatever was approved previously beyond that in terms of covered benefits, like as long as that's still true, then I think it should probably stick for the 90 days. I think that is the industry standard. And this is Danny Kier from MCG, by the way, but like all the step therapies, asking you to do an x-ray before you get an MRI, all that stuff, the patient shouldn't really be expected from our perspective to go back through all of that. The rest of the prior authorization beyond the covered benefits piece should hold between payers from our perspective.
Gotcha.
I guess,
So, go ahead.
I guess I just worry about it with Medicare Advantage plans as we talk about that, because a lot of times the Medicare Advantage plans, they follow the Medicare rules, but they also make you bill them as if they're a regular commercial plan versus a Medicare plan. So, I mean, I think that you can't carry it over, like you say. I mean, that, it's different it's different if I'm closing down, like I'm a Medicare Advantage plan and I'm no longer going to accept Medicare Advantage plans patients as of January 1st. Normally, yes, then you give like a 90-day period for patients to transition to a new provider or site of care.
Yep.
But if it's just, I'm Susie and I plan to change insurance plans, then guess what? All bets are off. I mean,
Excellent point.
at least that's the way it's handled today. That doesn't make it right. But that is the way that it's mostly handled today, at least in my experience.
Good. We'll go Stanley next, and then Michael, if you could unmute Mike Dennison. I'd like Mike to talk about the No Surprises Act comment here that he just made. Stanley?
Yeah, and not only are they asking about specific the time frame, but specific medical conditions, and certainly if we're talking about life-saving procedures, there's got to be some sort of a continuity, whether it's a drug or some other medical procedure. If you're obviously this is extreme, but if you're getting a dialysis in the hospital and you change health plans, I mean, you can't stop that for 30 days or whatever while you're waiting for another prior authorization. So I think if we're talking about limiting it to specific life-saving medical conditions, that would be a lot more acceptable than just any prior authorization.
Yeah, and usually life-saving, if it's emergency, wouldn't require a PA. So I'm not sure if that issue would apply. But let's, Michael, if you can unmute Mike Dennison. Mike, if you want to just raise the No Surprises Act issue.
Yeah, happy to. So basically, under the No Surprises statute, we have yet to see, any future rulemaking around this. But the statute does say that, that 90 days into the new plan, you must honor the previous plan's, policies, procedures, treatment plans, and I would assume that includes the prior authorization. So if a plan, if the former plan had said that prior authorization, that service has been approved, and that that treatment plan is then underway, then I would think that the new plan would then have to honor that.
So
As part of the continuity of care for that patient.
yeah, and I think what I'm hearing is a lot of support for this continuity of care when the service or item is part of the receiving plan's benefit package. I'm not hearing a lot of support for forcing the new plan to cover something that is not in the benefit plan offered to the patient. And I'm also hearing that probably 90 days makes the most sense, as that is sort of the standard of care currently today. If maybe a show of Diana, please.
Can you hear me? Okay.
Yes. Yeah.
I just, okay, I'm not going to be mean, okay, because I'm Michigan Medicaid. So I look at this from a government perspective versus a commercial. Medicaid, we got to go what's best with the patient. Whenever we deny a service, we tell you why we deny it. We give you explicit instructions, whether we didn't receive documents or whether we didn't get the information we needed. But we will respond with, you do not qualify for this, but you do qualify for this, and give alternatives. It's one of the good things about having Medicaid. We give you alternatives. We don't just say no. We say no, but you qualify for this. But here's my no-brainer. If somebody needs a life-saving treatment, a life-saving drug, dialysis, something like that, it almost seems to me that it would be a no-brainer not to stop that treatment or that antibiotic or that medication. Okay. If there was a group of quote unquote life-saving treatment, surgeries, whatever, that everybody in the industry agreed with, that would be great. I think it would be awesome if somebody went from Blue Cross Blue Shield Plan 1 to Blue Cross Blue Shield Plan 2. This would be a lot easier to the new payer just accept the previous payer's prior auth. My biggest thing is if somebody's going from commercial to Medicaid or Medicaid to commercial, Medicaid cannot tell commercial, oh, it's RPA, so you have to accept it. That you cannot, a rule cannot propose policy. It cannot mandate policy. Otherwise, if you're going to start doing that, you might as well just go to one national healthcare plan for everybody. But there are certain things that, yes, every payer plan needs to say, okay, this is life altering, this is life necessity, this is necessary. Then yes, okay, we'll carry it 90 days, good to go. But we still have there are things that commercial is going to cover that Medicaid's not. There's things that Medicaid, Medicare is going to cover that commercial will not.
So
And a lot of patients, when you go to a business, I don't know, you can pick which plan you want, whether you want Blue Cross Blue Shield, whether you want Blue Care Network, whether you want Sparrow Health, Physicians Network. Usually when you go to an employer, they have multiple plans that you can choose from. Okay, that patient is not going to understand every drug, every procedure that they're currently doing is going to have the knowledge to go and look at each insurance plan to see if what they're already being treated for and drugs are covered under the new plan.
So I think what we were discussing as a potential response from WEDI would be along the lines of if the benefit that the patient is receiving currently in the current plan, if it's also part of the benefit plan of the receiving plan, then there should be that continuity of care. I don't think we're hearing a lot of agreement that if a plan is not, if the new plan does not support that service or item, they should be forced to. So I think it's more so to eliminate the potential of a gap in care between the old plan and the new plan. I think that's the intent of also the No Surprises Act. But Mike, I see your hand up.
Yeah, I think maybe we should also comment that the industry continues to await rulemaking regarding
Correct. Yeah.
care.
Yeah, that's a good point. Good point. All right, I think we can move. We may have a poll slide here. Yeah, we do. So again, let me put the caveat here that if the new payer has the benefit in the benefits package for the patient, assuming that, should the prior auth be honored from the old plan. So again, if it's not in the benefits package, let's exclude that from this question. And life saving is one thing, but I think there's also cases, pick like an arthritis drug, where if you're off it, it could really impact your quality of care. It might mean you can't go to work, things like that. So there's that gray area between emergency and sort of maintenance. So it looks like pretty strong support for allowing that prior auth to be honored, assuming that the service is in the benefits package. Right. So, yeah, and so as Janice says, it can take months to get back on some drugs to be effective again. So I think that was kind of the point I was thinking about. Excellent. Okay, we'll close that, and I think we can go to the next slide, Michael. We're making pretty good progress here. And now this gets into what Derwin raised earlier. So it's very interesting how CMS phrased it. They go through this long-winded explanation of a phased-in process, only to say at the end, "Oh, we decided we're not going to do it." So I thought the way that they described it was interesting. But they basically, just as Derwin said, talking about phasing in PARD over several years. And it gave, again, plans a little bit more time to build in their policies, a little more time to get ready. The vendors would have a little bit more time. So we'll open it up for discussion on phasing in the APIs. Janice? and then Bob.
So 2 points here. First of all, as Ed pointed out, the hardest part of this is probably digitizing the rules, and that's really the first step for any of this. So it's hard to argue that a phased plan would gain much from that perspective. And although there's the whether phasing it in, it might help a little bit if you do X percentage, Y percentage, but that's kind of leading to a Wild West unless there's agreement on what type of PAs get phased in when, because if one group of, and who decides, is it the payer or is it it looks like they're saying the payer here. So if payer A requires this 25% and payer B requires a completely different 25%, and someone else, there could be a requirement for much more than 25% support for part of the exchange. So I think that's an interesting idea, but to me it seems like a bad choice, although I think it's more viable to require the CRD portion and then the DTR and the pass. But even there, the majority of the work is in the first step.
Gotcha. We'll go Bob and then Ed.
We've had this conversation on the standards calls repeatedly. Any phasing in of items and services, and I'm not talking functionality now, we'll talk about that in a second, puts the provider and the member at risk. Because as you said, depending upon which plan covers you, you may get an answer of, yeah, it requires prior auth. The other one may be saying, I don't know, I don't have any information. Or for different services, even within the same order, you may get one that says prior auth, one that says, well, I don't know. The I don't know forces you to go to the portal or something else. Most providers that we're aware of, if that's the situation, are just going to say, forget it, we'll do everything on the portal. In other words, they won't adopt the technology. So being able to have 100% of the items and services available on a particular date is really an adoption issue, not so much a implementation cost issue. Being able to separate functionality is a different set of problems. It may be entirely appropriate to have certain functionality described by these guides required by 1/1/26 and other functionality required at a different date. So we phase in the functional capabilities as opposed to the services and items capabilities.
Good points. We'll go Ed.
Yeah, Bob, that was really interesting. I'm going to put something a little bit counter to what you said, but hopefully it's complementary towards something your concern. When we looked at the transparency and coverage rule, which was for commercial plans, they came up with a list of 500 different procedures that they said, gosh, you have to have this in your portal, right? And you have to be able to display the costs for these. And you were allowed to substitute some, but for the most part, they actually specified which ones. And I would suggest from an industry perspective, from a CMS perspective, they would know what the most common prior auths are, or maybe perhaps even which ones are most critical to get answers for. And if they could give us a list that everyone would have to adopt and maybe able to substitute or add a few that are meaningful to your particular region, that might be a way of doing it. So not necessarily 500 of them, but the most common ones. And perhaps that way it would ease the burden on the payers to get some of those medical policies digitized, especially those that are just no's. That's the ones that concern me the most.
Excellent. Bob, you got your hand up again?
Yeah. Let me respond to that. We looked at that one. That was basically the approach that was taken when the December 2020 rule came out. One of the issue, again, feedback from providers was, well, that's all great, but if I have things that don't give me answers as part of the electronic prior authorization process, I'm still going to have to go to the portal. If I have to go to the portal, I'll just go to the portal. So it became an issue of adoption, not an issue of, well, I've covered the 500, because the others happen on a frequent basis too. The second part of it is, if we're focused on the question, do you need prior auth? That's a simpler question than focusing on the documentation that's required to support a prior auth, which is a far more complex issue. So the recommendation that we came up with in general from the group was all items and services for the ability to go and identify whether prior auth is required or not. And if there's going to be phasing in, it would be on the ability to automatically collect the documentation to support it.
Michael, go to the next slide, and then we'll have Diana go next.
Do you want me to talk before or after he goes through the next slide?
Oh, no, please go ahead.
Okay.
No, yeah, there you go. Thanks, Michael.
Oh, okay. I agree. We don't need to phase in. We need to do it all. If you're gonna go do it for the top 500, that it would seem so easy, right? 500 procedure codes, right? But then you gotta look, is age involved? Is gender involved? Is there limits like 1 per year, 2 per month? Is there things like, oh, but you don't need to be PA because you have this diagnosis code. And then it's like, oh, I'm sorry, your provider, 1, is not a registered provider, or 2, your provider is not allowed to perform that service or procedure or prescribe that drug. And you want to phase in and phase out. If you're going to do all that work for 500, instead of picking and choosing, it'd be better just to do it all, do this for all the service codes and not just for the top 500, because it's the top 500 in the industry. Doesn't mean for provider A and provider C, it's one of the 500 they do. So then are you going to do the first 500 for surgical, the first 500 for dental, the first 500 for DME? The first 500 isn't going to cut it. You need to
Gotcha.
do it all.
Yeah, excellent. Before we go to Stanley, I think I'm going to propose a potential response from WEDI, and that is that we tie back into what we appear to have gotten consensus on, and that is that the compliance date should be 3 years past the effective date. And so you wouldn't need to phase in if you've got a delineated timeline. If you go to the previous slide for a second, Michael, they talk about, January 1, 2027. Again, that's all predicated on a start date of January 1, 2023. So if you take that out of the equation and you build in a guaranteed 3-year window, to Diana's point, you do all of your services, so you wouldn't need to phase in. Stanley?
I think you're just talking about here requirements versus a suggested implementation process. I mean, my guess is that when a health plan is implementing this, I mean, they'll build the technology, and then little by little they'll start putting in some of their rules and documentation requirements. So naturally, they'll sort of implement on a piece by piece basis. Once you get a final date, you'll know everything has to be done by that date, and that way the plans have the opportunity to implement in the process that they feel most comfortable with, whether it's everything done at the same time, or a few of the PA documents and rules being put into an electronic version. You're going to have to be testing this out anyway before you go live. So this kind of phased-in approach will happen naturally.
Gotcha. Good point. I think we can go to the poll slide, Michael. I think 2 slides. Yeah, that's it. So just interested to hear your perspective on phasing in. So level agreement with the CMS statement. We do not believe it is necessary to propose phased implementation strategy. So if you're agreeing with this, then you're agreeing with CMS not to phase in. If you are opposed, then you would like to see a phased in approach. It looks like we've got general agreement that a phased in approach, and I'll put the caveat in here that we do need to have a delineated set of a delineated timeline for implementation. So it can't be this January 1, 2026, because who knows when the clock actually starts with the publication of the final rule.
Yeah, but Rob, this is phasing in of the rules,
Correct.
right? Not necessarily phasing in of all of the requirements of this particular regulation.
Oh, no, correct. You're talking about PARD. Yeah,
Yes.
exactly. Yeah. All right. Looks like we've got a pretty good consensus around strongly agree that CMS is making the right decision not to phase in here. All right, good. I think we can go to the next slide. And so here we have before 2026, they're acknowledging that payers might elect to maintain their existing PA processes until the proposed implementation date, but we would encourage them to develop short-term mechanisms to make prior authorization information more easily understandable and publicly available to providers and patients. So this would not mean that they expect you to implement PARD ahead of time, but they are looking for health plans, at least those impacted plans, to come up with solutions ahead of time. So maybe we'll start with you, Stanley.
You know, most of the requirements in this rule are based on the fact that there are different prior authorization processes in each plan. It seems to me that one of the recommendations that CMS should make would be for plans to work together on common prior authorization criteria. That would eliminate the need for many of these things, like the different, trying to download the different requirements from different health plans. So I think these short-term mechanisms, perhaps another recommendation could be added in here for WEDI to recommend some work to be done across Medicare and Medicaid plans on making prior authorization the same or as common as possible.
Interesting. Jenny, I see your hand up. Welcome.
Thank you. I agree with Stanley. I think when we look at legislation that's being proposed in over 40 states across the country, almost without exception, there isn't a requirement yet to be, pushed through the sausage making that is legislation, but a requirement nonetheless to standardize medical necessity criteria for very commonly for services that frequently require prior authorization. It doesn't mean that they all have to be without prior auth, but they need to share the same medical necessity criteria. Obviously, the health plans, I think, are going to be opposed to this, but I think from a political and a cultural and less of a technology or a policy perspective, this is in the winds. And health plans, I think, are looking at this and attempting to understand how can they work with their clinical decision support vendors to get a handle on what might be the top 500 services, for example, and focus on lowering burden, not only by creating technological complexity, paving the cow paths, but eliminating the need in the cases of services that are very frequently used.
Interested if our health plan participants want to comment on the idea of should WEDI be recommending that, again, pick a number, top 500 services or items, and we come up with a standardized medical necessity policy. You could see kind of both sides, but I'm interested in I'll pick on Derwin. What do you think? Would that be of interest to Blues plans, do you think, or is that a non-starter?
Well, I certainly don't want to speak for all Blue plans, but I would say that hearing the conversation beforehand about, the phasing in approach and stuff, that I can appreciate not doing that, because what's the benefit, right, for doing it partially, part way, and so I would think not, that we would want to go ahead and propose that do it all.
Gotcha.
Yeah.
Does this also apply, and maybe I'll have comment on this, to the documentation template? So if we have a standardized set of medical necessity requirements, could there also be a standardized documentation template for some delineated group of services, again, to reduce the complexity on the provider side? I don't know, go with Janice, and then ask Bob for his opinion. Janice?
Yes, hi, this is Janice again. Yeah, I actually raised this issue last week, I think, but Massachusetts is considering that approach right now. And if we are standardizing on, if we go to the point of standardizing that these X number, whether it's 500 or some other number of services are standardized, have standardized rules, then there's no reason they couldn't have standardized documentation templates, forms, questionnaires, etc., all of the things that go into that combination of things. And in fact, it probably would make that easier. And I know that within our data governance work group, there has been a lot of positive response to that idea.
Good. Anybody willing to give the other perspective, that would they don't think it would be valuable, or they don't think it would be feasible to create these standardized processes and templates? Derwin?
Yeah, I kind of agree with Janice as well, because part of the CDEX, and Bob can probably speak to this better than I can, but part of the CDEX stuff that we're talking about now is to standardize some of the questionnaires and stuff that being developed. So I think that would be a good step towards what Janice is talking about, but that's a progress in work, I'm pretty sure. So.
Derwin, any downside for the health plans of going down this road?
Yeah, well, that's the one thing that I think an advantage to going with CDEX is that it allows you to do these questionnaires and not ask for the full medical document. And so establishing some of the commonality things that we ask for, what's the last A1C or something like that, would be, I think, very appropriate. So.
Thank you. We'll go Diana and then Bob.
Okay, I'm lowering my hand now. Okay, I can understand that maybe a payer could standardize a form for that specific plan, because I know payers have more than one plan, or that specific group of codes, DME or something like that. I do not think you're going to get a standardized form to go across multiple payers or across countrywide, because each state has different requirements due to whether it's a commercial or a government. If it's a government, you have each state Medicaid has a different budget, has different rules they have to do. But here is a thing. There are, I forgot what I was going to say. I forgot what I was going to say. Never mind. I'll think about it and come back.
Okay. We'll go to Bob.
Yeah, we have had an effort at HL7 led by Melanie Combs-Dyer to try to standardize some of these requirements for specific services. And we found that it is absolutely difficult at best, unless you're talking about relatively trivial things that everyone agrees on. we designed the documentation requirements process to allow providers to have whatever it is they need as far as clinical information to support medical necessity and appropriateness, as long as it is part of the medical record and accessible through the FHIR APIs. So basically, that does provide a set of constraints. Once you go past that, now you have to interact with the provider or their staff to get additional information. And that creates somewhat a break on both sides to basically say, is it really worthwhile doing something that's not currently represented in the structured documentation that's available through the APIs? So we move that direction to say this becomes our basic platform, is use the things that are there. It's much less important that you all use all the same things, as long as you use them from the same, if you will, set of definitions.
Yeah, I think that's an important issue, that the templates can be different, but they all need to sort of draw water from the same well, right?
Exactly. If you're going
And
to
if you
need,
go-
if you're going to need conditions or diagnosis, here's how you get them. If you're going to need, lab tests, here's how you get them. If you're going to need, a record of prior procedures, here's how you get them. Okay, we don't care so much that for one payer, you need this condition, this observation, this procedure. We only care that you get them the same way, and that reduces the burden tremendously because that's all electronically available.
Yeah, exactly. And Ruby says in the chat, answering questions has as much or more value than exchanging an entire patient record. And I would assume that applies both to providers and payers. So if it's a more structured data, it's going to be a lot easier for the plan to adjudicate that request and meet the potential, the 7-day turnaround time, rather than getting a entire medical record and having to go through it sort of piece by piece. We got Diana, and then we've got Nancy.
I do agree. If someone has to send the entire patient record, yes, they would probably want to answer a form. What's the A1C? What's the diagnosis code? That's all well and good. But, and I know government payers are a small portion compared to the whole healthcare industry compared to commercial. But as most government payers have to do is, we do not say you have to fill out this form. We are making it as easy as possible for our providers, because let's face it, a lot of providers don't want to be a Medicare or a Medicaid provider because, we pay the least. So they'd rather play the big commercials. So we say, okay, you want to be a Medicaid provider? This is the information we need. We don't want you to fill out another form. You're busy. Just send it to us. We need the A1C, whether you've got it on, if you want to fill out the form, great. If you have it where you've got it written down in the record, great. We need the last 3 days of patient notes. We need the last sleep test. We don't care how you have it annotated. Just send it to us, whether it's structured or unstructured. We don't make that demand. So we don't want to put the demand of you have to fill out this form, because that's just asking our providers something else they have to do, when we want to make it as easy for them as possible to send us the information the easiest way they can.
Gotcha. Excellent. We'll go Nancy and then Janice. So Michael, if you could, all right, we'll get.
Okay. All right. Thank you. Yeah, because a minute ago it told me I couldn't unmute myself, but it let me then. So, I've been sitting here and I've been listening, and, our overall goal is to attempt to ease the burden of sending information for prior auth. For one thing, transmitting the prior auth itself, but then, the attachment, sending the information. And if we don't standardize what is sent to a certain degree, then we are not reducing the burden for the providers and the practices. If they have to keep up different standards for different payers of what to send, that's not going to help them any more than it. Well, if they can send it electronically, that will help them a little bit more, but they're still going to have the burden of having to maintain which payer wants what and in what format. So unless we can agree on some kind of standardization of basic data that's sent and in what format, I don't know how much of the burden we're going to reduce. For instance, if people are using a certified EHR, they have to have the ability to create a CDA or a CCDA. So could we standardize to one of the basic CCDA templates that just sends basic information? Is that an option? I don't know. You know, I come from the financial side of our product, but you know, I have been looking at all of this stuff about electronic attachments and prior auths and everything for several years now. But you know, so if we don't standardize to something like that, and the industry has to agree, and it has to agree to say, well, for instance, you know, we're Medicare, we don't care how you send it to us, but if we standardize a format, will you take it? You know, there's got to be some give and take amongst all of the payers for us to come to a standardization.
Yeah, no, excellent points. We'll go Janice and then Bob.
Hi, Janice again. Just a quick response to Diana and then the point I was going to originally make. Just to be clear, at least from my perspective, the questionnaires that I was talking about at least were fire resource questionnaires that would have to be, most likely have to be created in order to make the PARD API work. So it would be taking questionnaires that you would have to create that would be individualized and creating standard resources that everyone could use. So that was sort of the point there, at least from my perspective. But to my original point, the other advantage that we haven't talked about to having some of the standardized and the actual data collection standardized is that makes the other components of the rule a lot easier. The prior authorization components of the patient access API, the provider access API, and the payer to payer. Because remember, one of the requirements there is that all of the data that was used to make the prior authorization decision has to be part of those other APIs. And if we have a standardized data set that gets collected, it's much easier to then translate that data over into the other APIs. Whereas if that's all over the place, that becomes a much harder issue and problem.
Good, excellent, thank you. We'll go Bob, and then we've got a couple of issues to discuss here. Go ahead, Bob.
Want to make it clear that what we've done with the prior authorization implementation guides is to require support for the things that ONC has required for certification. These are things that are required of every certified EHR. We're using those as the item that you can select from in the questionnaire, and it is a FHIR questionnaire, as Janice had indicated. This is not something where each payer gets to make up their own. They have to use the set of things that every EHR has to certify. Can they do something above and beyond that? Yeah, but that requires manual intervention. So the goal is to focus on those things that are available electronically to minimize any kind of provider interaction. If you can have the questionnaire come in and we have the process for it, interrogate the clinical record, pull that data back without provider intervention at all, it massively reduces the cost to the practice to be able to respond to any kind of documentation requirement.
Thank you. Two quick points. One, I wanted to respond to Becca's comment, which is spot on. We do have a slide towards the end of the deck where we talk about this, because here we are assuming that every provider has a certified EHR. That's not the case. Certain providers, including dentists, pediatricians, behavioral, a lot of them do not participate in MIPS. And so they use a very specialty specific EHR, which may or may not be certified. So we need to be thinking towards the end of the program today of how we can incentivize these vendors and these providers to be able to take advantage. The other issue is back on the screen, we've got the last sentence here, more easily understandable and publicly available to providers and patients. One of the things WEDI might recommend is for CMS to encourage all health plans to publish their medical necessity requirements for at least their top services, make it easily accessible for providers and others to understand. That cuts down the work on both sides. So providers will know what is required before they submit something for approval. Celine, you've got a comment?
Yeah, Rob, thank you. I appreciate that suggestion, and I was gonna maybe take it one step further, if possible, to recommend that it be in a centralized place so that providers don't have to, and patients don't have to go out to each different payers. Perhaps CMS could consider housing, a centralized space with that information as well. And that goes for all the public reporting requirements that are listed in the rule. That would be our hope from the provider and patient perspective.
Yeah, that definitely raises some issues about maintaining that database, making sure the information is fresh. At a minimum, Celine, what would you think about trying to have each health plan have a very publicly accessible area on their web page, where there would be a relatively standardized signal or button where their policies would be presented. It might be a less cumbersome than trying to have the government collect and display this. Yeah. So let's go, Chris, and then Daniel.
Just a couple of comments about the provider vendor issue here. Burden reduction requires change, and that change cannot only occur in the regulatory and on the payer space. Providers, if a provider wants their burden reduced, they are going to have to change something. And that might mean that their practice management or EMR has to change, whatever, but it is unrealistic and it is an impossible ask to say that a provider cannot be required to make any changes at all, and yet we're going to reduce their burden somehow. So there's that. And then the other comment that to address what was just being talked about, I don't know if it's all markets. I know we already do publish our medical, I forget the policy term for it, I apologize, but our PA requirements are published on our website. As far as getting, I would certainly support, and I believe we use probably the same format across the board. However, I do believe there are variations in that as mandated by various states. And so if we are going to do that, we need to be aware that that is probably not a format that can be imposed simply at the national level. That is something that will have to work with each and every state as well. I know our Medicaid businesses, the individual states will require their own personal touch based on the history and tradition of what they've traditionally done in those states. And so standardizing these things across the board, especially to what someone else was talking about in the Medicaid space, where perhaps providers aren't keen on being part of Medicaid in the first part, it can be challenging, again, because it would require changes to what they've been used to doing for potentially decades.
Sure. And when you think about it, if CMS, again, they're using the term encourage, so they're not requiring, but if they're encouraging, either CMS or industry develop a template for how to display the policies, not to say any plan has to follow the policies of another, but at least display the policies in a consistent way to make it easier for those providers and patients trying to access them. So that's another option. Daniel?
Yeah, Danny here from MCG again. I dropped to take a conflicting call, but I'm back. I think with this requirement, I think in the rules and in the suggested implementation guides, that format is there, right? The HL7 fire questionnaire format is the sort of template for which at least EHR presentation of these policies is expected to be. I think for this, when we talk about having a button on to get to the prior authorization requirements, I think almost every payer on provider.bluecrossblueshield.state.com is you can always find, UHC, you can always find their medical policies. It's just, is it where I want it to be as the person who wants to be interacting with it? And I think the answer to that is generally no. I mean, it's the same issue. I just tried to get my license transferred from one state to another. And it's like, you had to go to 5 different places to find random things that you almost never try to find. And it was like, I'm not doing this. And I think that's what providers are saying here too, is I'm not going to go to 3 different places to find this, whether, I work with this payer. They have a commercial business, they have a Medicare Advantage business, they have a commercial exchange business, and then they also do some of the state Medicaid where I'm at. And it's like, I'm not going to go to the Medicaid thing for their policies. I'm not going to go to their site for their commercial policies, and to the exchanges for something else. I think they're saying, no, put it all where I want it in my EHR. And I think the template for that this rule is suggesting, or at least strongly encouraging, as we talked about a little bit earlier in this call, is that fire questionnaire format, which should be do this from our perspective. We've implemented this, and we've implemented something we think would be compliant with this. And that's worked out just fine.
I appreciate that. And I think the one thing we can agree on is we are not going to look to state motor vehicle administrations for burden reduction opportunities. So I think with that, we can go to the next slide. So we are talking now about the requirement, again, starting on January 1, 2026, that payers would be required to provide a specific reason for denied prior authorization decisions, of course, excluding drugs, regardless of the method used to send the prior authorization request. So very important last piece there. I don't know, Daniel, you've got your hand up. I don't know if you want to comment on this or if it's still up. Okay, good.
It was still up, sorry.
Yeah, no worries. So we'll go Stanley.
You mean that payers deny prior authorization without giving any reason today?
Well, that's a question for the payers, I think. Chris? Yeah.
Yeah, Stanley, I kind of had the same reaction as you did to that. We do give reasons for our denials. We went through a fairly extensive mapping, and we've even requested a couple of additional denial reason codes with X12 to better map to our internal rationale. From a payer perspective, and payers, if I'm wrong on this, please speak up. I thought we would be doing this simply for our own benefit, so that people wouldn't call us and ask why it was denied, because of picking up that phone call is extremely expensive, and we'd rather just give it to you right when you're most likely going to be wondering. So Stanley, I'm in the same boat as you. I don't understand why a payer wouldn't do that.
And given that most of the impacted payers are already managed by CMS, Medicaid managed care plans, CHIP managed care entities, and others. I'm not sure why there needs to be a regulation on this. I don't know what they don't just say to as part of their contracting process, this is what you have to do. So, I mean, I don't understand why anybody doesn't do it, but this is an excellent question.
Yep, excellent. Ed, then Celine, then Daniel.
Yeah, thanks, Rob. My only comment is it'd be really nice if you actually name a specific code set. You know, I think it was just mentioned that X12 has one. I think just make sure that code set has all the reasons and people exchange that in a very standard way.
So Ed, are you suggesting that that would be part of our comment?
That's what I would suggest.
Okay. And we'll go to Celine and Daniel, but I'm interested to hear from others about naming a specific, kind of like a Kark and Rark, a specific code set. So payer to payer, the provider would understand exactly why the PA was denied. But we'll go to Celine first.
Yeah, from the provider perspective, we definitely commend CMS for proposing, improved transparency. We think it'll be very valuable for patients when they select a plan, and also for benchmarking against the proposed technology for PA burden reduction. But we would love to also see the public reporting strengthened through, again, we talked about this earlier, but disclosing PA clinical criteria. And then to your point, Rob, a more granular level of information, for example, like at least by category of service. I mean, it would be helpful to aggregate that data and on a granular level. And then again, I realize there's issues with publishing this, the maintenance of a website, et cetera, but it would be very valuable to have a centralized public website, I think it was Dan's point earlier, it's really challenging to find these pieces. And a lot of times this information, if it is available, is very much buried. The one thing that I said in the chat is the timeline. We strongly feel that there's no need to wait until January 1, 2026 to make these this reporting required. The payers have this data, and it could actually be really valuable as a baseline to evaluate the improvements of PA as payers are developing this technology for the burden reduction to actually have this information and to have this be required sooner.
Good. And we'll go Dan, and then maybe Mike, I'll ask you, Mike Dennison, to maybe talk a little about the 271 and the X12 code set. But Daniel first.
Yeah, there's an X12 list mentioned in the rule. I think it's the 278 list. My memory serves, but maybe I think somebody else said it's a 271. So I would have to go back and check. But there is a list that the rule names for the codes. And I think I agree with the folks who are saying the payers already do this by and large. That's awesome. I think what we've seen is having a standardized list. So think about the providers. They get a decision back into their EHR. Now they're expected to do something about that decision, and they've got humans looking at that decision. If the reason codes are not standardized, it's not just that we need a reason code. I think CMS is looking at this to standardize the reason codes, and the reason being is there's a human looking at all the different payers' reason codes right now. If they are standardized, they can actually write automated rules in their EHR to send these different decisions down different paths. I think not just denials, but also pending things. If the request is pending and it needs additional clinical review, if that comes back in a standardized way, providers are able to automate that path of, okay, now there needs to be somebody to do something about this. I can send it to the right work queue. And that from MCG's perspective, again, having done this once or twice already, we see providers doing that when they're able to do that because of the standardized nature of it, not just the reason codes themselves, but making them so that every provider can write a set of rules about what they want to do downstream from that decision coming in.
I appreciate that. We're going to go Mike first because I called on him, and then we'll go to Janice.
Yeah, thanks. Yeah, I think it's been mentioned in the chat here a little bit, but when I say X12, 278 version 5010 X217, I specify the X217 because there are 3 flavors of the 278 to support the prior authorization request for review, the notification, and the status of a review. So X217 is the HIPAA named transaction standard for 278. And there are decision codes, and Chris just put the link there for that list of decision reason codes. And, there is also a maintenance request. So if there are additional decision reasons that are not in that list, it's as simple as submitting a code request and maintenance inquiry via that form.
Excellent. Appreciate that. And we'll go to Janice.
Sorry, I had some trouble unmuting. I pasted into the chat the quote from the rule. It's not, they however talk about both automated and manual and portal processes, which is, I'm not sure why they do that, given that this entire process is supposed to require the automated prior authorization process. So I'm a little bit confused by that, but the specific thing that they said was that if you're using an automated process, you have to use 278's codes, and if you're using a manual process, you can use custom codes. So that's a little bit confusing to me, but there you have it.
Mike?
Oh, sorry, I didn't put my hand down.
Okay. Okay. The one thing that appears clear is that there is a code set, but it may not be exactly what the industry needs. Is it fair for WEDI to encourage use of the code set, but also encourage a review of the denial reasons and update the code set as required? Is that a fair comment from WEDI? I don't know, Mike, what do you think? Okay, Chris? Okay. Oh, sorry, Mike. Yeah, you're back off mute.
No, I was just, go ahead, Chris.
Oh, unmute. There we go. Okay. I was just going to say, I think it would be appropriate for WEDI to go, yeah, exactly what you were suggesting, recommend use, expanded use of this code set, and both payers and providers, if there are issues with the level of specificity in these codes, that's something that can be addressed. There is a process in place. That process has been in place for a number of years, and I would just call out, this HIPAA mandated transaction has been out there for 15 years. If people have been trying to do electronic transactions, they've been able for 15 years to say, wait a second, these code sets are insufficient. So I don't see a need to create one from scratch when we've got one that is mandated for electronic uses. And if it's simply a matter that we need additional codes, let's request those additional codes.
We'll go Chuck and then Celine.
Chuck Faverka here in support of Michigan Medicaid. We have specifically discussed, could we use a code set in our responses as reasons for denial? And in certain instances, that is correct. However, under Michigan's legislature, we are required to send a letter to the provider and to the beneficiary explaining the decision and the criteria for making that decision. In that letter, which is also available online through our portal, okay, everybody wants to move away from portals, got that. But in that letter, we also, as Diana has previously mentioned, make alternative suggestions, or say, you know, the maintenance on your wheelchair can only be performed so X number of times in X number of years and things of that nature, which would be cause for perhaps a denial of a PA request maintenance on a wheelchair, but could be addressed in another manner. And if we only rely on a code set, the variety of responses that are verbalized in a letter back to the submitter, the requester, it's always going to exceed the number of codes you can come up with and standardize. So if we go with a code set, that code set also needs to be able to handle in parallel a verbal response from the payer to elaborate on the decision. That's my request. Thank you.
Okay. Thank you, Chuck. Celine? Like she took her hand down. So, go ahead, Celine.
Sorry, I was trying to unmute. I was just, I think Dan may have said this in the chat, but basically, you know, I have to respectfully disagree with Chris. I understand that it's nice to have the X12 code set available and we can build upon that. But the problem is, you know, we'll be beholden to X12 processes, which, as I understand it, you can really only update these 3 times a year. And again, the specificity issue is really the issue at hand. So I think we need to consider that. As to your question, Rob, I think this is a great spot for WEDI to weigh in on, and it'd be very, very valuable for patients and providers alike to have, you know, very granular denial reasons codes. So.
Well, Celine, if, oh, sorry, Michael, if you can unmute her. If that's not the right code set, then what is? And 3 times a year, as Pam says in the chat, that's fairly rapid turnover of codes. Can you explain more about your pushback on that?
I guess because I've been part of, you know, and I understand X12 has changed their processes quite a bit, but, you know, back in the day when I would go to the code maintenance committee, it was very much like maybe a state had a new law that required something specific for vascular surgery. And there were just very, it was either, you know, when people were thinking about the scenarios, it was really only after the fact, or because a law was in place that would require something, that someone would go and actually, you know, submit a code request. And I'm just wondering if I don't know, it's just, there was, the process itself was very much like either after the fact, or it didn't really keep up with the pace of industry and the needs of industry. And, you know, I could be wrong, and I'm sure Pam will interject here. But, you know, I just, again, I'm not opposed to building on the X12. I do think that it needs to be more specific. And part of that is us as an industry making sure that that's communicated. But another thing that Bob mentioned, which I agree, is, you know, there's also a need to know post-denial, what can the provider do about it, you know, and what are the mechanisms? Is it, you know, is it you need more information? Is it not covered? There's a lot of lacking information that needs to be teased out that currently this list doesn't account for. So something else to think about.
Gotcha. So almost like a potential next steps for the provider. If you don't mind, Mike, I'm going to go to Pam first. I think she's probably got some comments on this, and then I'll go back to you.
Sure. She may say the same thing.
You may have been just waiting to say what I was going to say as well. I just wanted to elaborate on the codes process, which has been changed over the last few years and has become much more flexible. And the whole point is to be able to meet industry requirements. So anyone can submit a code request or a request for a new code. So as I think Chuck was saying, you know, or someone was saying, that they may be evaluating their internal codes and see that there's some additional codes needed because what's there doesn't quite use the language that's needed or whatever. Anyone can submit a new code request at any time. And then, so it doesn't have to wait on regulation to come out. It doesn't have to be someone internal to X12 submitting the request, or anyone can submit one. And then those requests are reviewed 3 times a year in conjunction with the standing meetings, and adjudicated at those meetings. And within 30 days, then if the codes are agreed to be added by the entire group, then within 30 days, those new codes are published, and along with an effective date. And just depending on which code list we're talking about, because the different code lists may have different requirements, but there's an effective date that goes along with it, so you know exactly when that code becomes effective. So it's I think a much more agile process than it used to be, and is an open process that anybody can contribute to.
Excellent. Go ahead, Mike.
Yeah, I'd like to add to Pam's comments. We also have to realize that the X12-278 has been a HIPAA named transaction since the inception of 4010. So it was actually almost 20 years ago that this has been a named transaction. And as such, even with PAS, there still has to be an X12-278 HIPAA compliant transaction created. That is still required. It's talked about in the preamble, and there's no, currently the way it is structured today, that X12-278 has to be created as a compliant transaction as part of the, FHIR PAS request and response process. And, being that the X12-278 is still required under HIPAA for all covered entities to comply with, then the services review decision reason codes are then also required. That is the required mandated list of reason codes that must be used.
Excellent. I think we're going to move ahead. If you have additional comments, please put them in the chat on this one, but we still have a ways to go, so I want to make sure. So let's go to the next slide, Michael. Okay, now we get to a big issue, and that is the response times. So to summarize, they are proposing 72 hours for expedited requests, or no later than 72 hours, and no later than 7 calendar days for what they term standard requests. They do ask for comments on whether or not to provide shorter time frames. For example, they say 5 calendar days for routine and 48 for expedited. So let's open it up. Maybe I'll turn. Let me see here. Let's Derwin. Let's go to. Let's figure out if the time frames are doable from a health plan perspective. I don't know if you have some thoughts on set 72 hours and the 7 calendar days.
Well, I guess I would favor the longer period of time, 7 days and
Yeah.
72 hours, rather than the 5 days, 48 hours. So.
Gotcha. So let's, Celine, let's hear from the providers, the AMA. I'm sure you have some thoughts on the timing.
Yeah, from a patient care perspective, we find these much too long. Back in 2017, we signed on to some principles with 16 other organizations that advocate for 24 hours for urgent and 48 for regular prior auth. When you think about the word urgent, would you consider something as urgent being done within 72 hours being done urgently? I don't think so. So we feel very strongly that they need to revise these responses. And then further, another thing that we really would like to see spelled out in the rule is that this is for final determination. It's pretty essential that, the final determination be made at that point. We don't want append within that time. That's not valuable for anybody, not providers, or especially not patients who need, medically necessary care. So.
No, good points. And yeah, just to reiterate, this is not the entire life cycle of PARD. This is after the health plan has received all of the information it needs in order to adjudicate. So let me see, who else can I bother? Stanley, you've been around this industry a long time. The times are interesting because it's the first time that we've seen sort of a hard deadlines on health plans. We've seen it on the eligibility side through the operating rules, but here they have deadlines for the health plans.
Yeah, and I was just going to say this is very much like an operating rule. Although I don't know the research that was done in the 7 calendar days or the 72-hour days, much like the comments on giving a specific reason for a denial. What are the average times on these days? What is the problem that it is that they're trying to solve, and are 90 to 95% of prior authorization decisions already meeting these requirements, or even the faster requirements, or not? I don't have the information on that, but you're right, Rob. This is very much like an operating rule, but I'd love to see the stats on that.
Yeah, that's a great point. And they don't provide any stats. It's not like they have done a survey of health plans and know exactly what the current environment is, whether it's faster than this or the same as this or slower. Derwin and then Marianne.
Yeah, and I like what Stanley said, but I think key word here is expeditiously as the patient's health condition requires, and certainly, if there's an emergency situation, it's done differently, handled differently. But I think, even today, it's done within no later than the 72 hours. So I think that would be the longest that it would go.
Yeah. And sometimes the government will do this, understanding that that's sort of the current practice. But here, of course, they're making a requirement rather than just encouragement.
Yeah, and I'm certain that certain conditions and the prior auth can be done within an hour or two versus, or for the most part, for the majority of them. But
yeah. Marianne?
Yeah, I think that putting some time limits on these are good. It helps to, especially if a patient is like transitioning out of a hospital into a different site of care, then they're staying in a hospital possibly for no reason because a provider is waiting for a prior authorization. So, and I think we're living in an area where I don't understand why it should take 7 calendar days for you to say yes or no if you've got all the information that you need. So, I mean, I think anything that we can do sooner this way, living in the world that we live in, that, everybody expects an answer yesterday. So having somebody wait just because you're waiting on a prior authorization, I think isn't prudent in this day and age, and we need to work to do better for the patients and get these quicker.
Sure. One of the challenges here is they're lumping all prior authorizations together in one bucket. So an authorization to get an X-ray is vastly different than getting approval for a very complicated regimen that could be hundreds of thousands of dollars. And so some you would think, oh, go ahead. Yep.
Right, but on the flip side of that too is something as simple as an antibiotic, takes 7 days that you're sitting in a hospital, that something that could have been, in the home with a Medicaid care or something like that. So that's why, providers are having to weigh the cost of not getting the prior authorization versus, and then you worry about patient care. So I don't I guess if we're going to say longer times, then we need to say, you know, why that is in a day and age where if we can do this electronically, and, you know, as we move towards providing prior authorizations electronically, I'm sure that there will be, you know, you've got this diagnosis with this patient with this age or whatever, that, you know, it should be able to be automated in some ways. And so then why have 5 calendar days and 48 hours? Why isn't it quicker?
Yep. Well, with that, Michael, I think we can go to the next slide because we do have actually, yeah, we can skip this and we'll go to the next slide. We'll go to the poll. So we're asking what response time approach do you most support? We've got the proposal, which is the 72 hours, 7 days. The one they're interested in finding out, the 48 hours, 5 days, or longer timeframes than that proposed, or shorter timeframes. And while we're doing that, Chris, you've got a comment? Michael, yeah, good.
There we are.
Yep.
Just on the idea of, you know, all the information being there and a decision should be able to be made. I agree with that, as long as the information was submitted in a computable format. If the provider sends in a fax or a PDF, that requires manual review. And so, you know, our standpoint at Elevance has been that we would only support the increased timeframes for when all of the information was submitted in a computable format, so that we have a chance to automate some of this stuff.
Gotcha.
It doesn't help us if there's a fax coming in.
No, and in fact, that might be something for WEDI to consider, is that maybe incentivizing providers to purchase the technology. If you use the Fire API approach, the turnaround time is shorter than if you don't. Much like you know, submitting electronic claims versus paper, you get paid faster. Is that what you're thinking, Chris?
More or less, yeah. You know,
Okay.
we can't, you know, if there is information required, obviously if no information is required, if we can just do it based on a request, you know, you hear a lot of people, you know, payers that do a lot of referrals don't need extra paperwork and they can just automatically approve stuff very easily. But when you're actually talking about inpatient admission or an expensive treatment that requires additional documentation, even if it's something as simple as, you know, the last 6 months of A1C values or whatever that value is, having to have a person look at that can slow things down dramatically depending on the volume of business that's come in, versus if we can set up, you know, an auto adjudication engine to, examine those last 6 weeks or what last X days of A1C values, and yes, that meets our criteria, it's automatically approved.
Great. Yeah. Michael, I think we can go to the next slide. Ed, you've got a quick comment?
I just want to make a quick comment to what Chris said. So I thought that was really insightful. My only call out just today and today's technology that maybe mid-market payers may have that don't have quite sophisticated systems, that it may be challenging for them to automate some of those electronic structured attachments. Long-term, I definitely agree. And also add in the future, man, if we had machine learning and be able to do NLP and all kinds of stuff, we should be able to really get those times down altogether.
Gotcha. Good. I think we can skip ahead. Michael, we've talked about the IGs earlier. I think we're good. I think we need to talk about this though. If you go back one side there. And Stanley, go ahead.
Sorry, I was just going to say, if it's computable at the health plan, why can't it be computable at the EHR level and have the rules built in at the EHR, so the provider wouldn't even have to send information to the health plan?
Yeah, that's really the goal, isn't it?
Yeah.
Yeah, no,
If
great
you've got the
point.
rules, then you should be, if you have the rules, then you should be able to know right off the bat if something should be provided or not.
Yep, good. If I can call on Bob to tie up. This is an interesting part of the rule because essentially they're requiring use of the 278. And I know you know this stuff back and forth. So maybe you can explain it and maybe suggest something that WEDI might want to say here.
Well, under the National Standards Group, who has responsibility for putting out standards required by HIPAA and ACA in response to feedback from the SDOs going through NCVHS, they have, as Mike indicated, almost 20 years ago, required a 278 for prior authorization. There are grandfathered approaches to that. They've allowed direct data entry. They've effectively considered portals to be that. So they've provided some workarounds to it, as long as a human was interacting, not for machine-to-machine communication. To recognize that we still have an existing HIPAA requirement, we wrote the prior authorization support implementation guide to ensure that all the information that was necessary to populate an X12 in 278 request was available in the FHIR bundle. And so we create a FHIR bundle, we hand it to whatever, whether it's a clearinghouse or an intermediary or some other functionality that can convert this into a 278 and pass it on through to whatever is going to go and communicate with the payer. Because there's not necessarily a requirement that the payer receive a 278, there's a requirement that it be in that format somewhere in the middle between a provider and a payer. And so we worked with X12 to do the mapping between FHIR and the additional extensions that were required to support it, and X12 in both directions, the ability to go and create a 278 request and the ability to go and convert a 278 response back into the FHIR bundle that's returned to the EHR or the HIT. So we've been respectful of the need to be compliant with HIPAA transaction requirements. We've also, as DaVinci, applied for an exception to that and said, well, this is interesting, but we want to test the ability to go and provide that FHIR bundle all the way to the other end without converting it to a 275 or converting back at all. And DaVinci was granted that exception, and any DaVinci, and you'll see this on a subsequent slide, any DaVinci payer can, in conjunction with a provider partner, as long as they sign an appropriate agreement, use that exception or test under that exception and be fully compliant with what HIPAA requires. So the bottom line is PAS meets the requirements that we have under HIPAA to support the 278, and the exception allows us to test an alternative without using the 278.
Excellent. Appreciate that. Michael, I think we can go to the next slide. And while we're doing that, Janice, please go ahead.
Yeah, for those of you who may not have been paying attention to the comments where this topic came up a while ago, we feel very strongly that in order for this to be a very successful process, that somehow the HIPAA requirements need to be changed, or at least discussed. And we realize there's that exception and that DaVinci has been granted one, but this is the first thing that we thought of. This is the first thing that comes up in every conversation we have about this rule. And people don't want to deal with the exception because it's only for 3 years and it requires a lot of documentation and reporting. And they don't want to make the investment for that in either time or resources or money. And it's really something that we feel very strongly about. And I realize that it's not something that CMS can do on its own, but having the current response is typically will apply for an exception, which is not a good answer for most of the people that we're talking to. So we would like to see as much pushback on this as possible.
Yeah, and as Chris said, the exception only applies to the payer and their one trading partner. So it's not really a solution at all.
Let me
Derwin?
clarify that.
Oh,
It applies to the payer that's a member of Da Vinci and any trading partner they wish to work with, as long as each one signs the agreement.
oh, gotcha. Okay.
There
that's
is no one requirement whatsoever.
Derwin?
Yeah, Bob just stirred up an old thing in my head here when he brought up the DDE exception for the direct data entry thing. Was that ever discussed as an approach? Maybe that would be. I don't know if you can equate it to fire, but it is kind of in that realm. But maybe it's a stretch.
No, in fact, I won't claim any credit. It was Stanley that first came up with the idea. So Stanley, I don't know if you want to talk a little about your concept here.
Oh, absolutely. And I think it is analogous to the DDE exception. I believe CMS has the authority to say you can use the X12 278 is the standard. However, if a relationship exists between a provider and a health plan that they want to use just the fire bundle and exchange that back and forth, that is an option. That a health plan could not require a provider to support it, and a provider could not require a health plan to support it, but sort of extending the pilot test, under agreement, the regulation could say that the fire is as an option. Now, the problem is that you've already got this ongoing pilot test, and the CMS response could very well be, well, we're testing it out to see how well it works. And if the pilot test shows that it's working very well, then we will adopt it as a standard. But I think the option can exist. The support that CMS would need is to see that it works, to see that it's as good or better than the 278, and that the industry is willing to support it as a standard. So I would agree that is a possibility in the rule. It may be a little early to request CMS to make this fire an option, the fire exchange an option, but it certainly can be noted in comments that it's a possibility. That's my feeling.
So you'd have to prove that it's faster and cheaper, right?
Well, I think you'd want to say that it is better instead of simply saying, well, we want this as an option. You'd have to give the rationale. If you've got a pilot test going and the pilot test is already showing fabulous results, why do you have to wait the 3 years before making this an option? And Rob, I don't know do we have a poll here that says whether or not they stick with the 278 or move to the fire? Is that one of the polls, or is that only on when we're going to be discussing the attachment rule?
That's good question. Michael, if you can go to the next slide. Okay, yeah, we do not. So,
Okay.
But let's maybe we could have first, Bob, you probably have a comment on this.
Yeah, let me just clarify what the exception does. It's something that is defined under HIPAA as how you can replace an existing standard. That's what it is. We applied for that. The process is you can have up to 3 years. We don't have to take 3 years to go and do the, if you will, testing of the new standard in production. This is a production test. This is not non-production information. At the end of that time, we have to submit a set of documentation to CMS. They will publish that in the Federal Register. It is then up to an SDO using that to make a request to NCVHS that the standard be replaced. NCVHS, if they agree with it, will send a letter to the Secretary of HHS, who will instruct the National Standards Group to go through the process of replacing the standard. That's the process that we're in. There's no shortcutting that I'm aware of.
But yeah, I think the point, though, I think that Stanley's making is we need to at least plant a seed with CMS that they need to look for some opportunities here. And they may come back and say, requires a statutory change. But I think we can make the argument that this revised approach that we've been discussing is better for the industry. I don't think, if anybody is opposed to that, Rebecca?
Can you hear me?
Yes, thanks.
My only concern with when we start thinking about changing from one standard to another, and I have no problem with the exemptions or anything like that, but especially as you think about where certain industries, especially dental, are right now, replacing the X12 standard with FHIR, and even if it's in 5 years, means that we are going to see attrition in all the CMS programs for dentistry. We're going to lose so many dental providers who are currently serving critical underserved populations because they're not going to be able to meet those requirements. So I just encourage everyone, as they're thinking about pushing forward progress, I don't want to stand in the way of progress, but think about the impact that this is going to have on small independent practices and providers and the patients that they serve.
Always wise to remember that whatever solution we come up with, it has to meet the needs of all, not just those larger providers with larger budgets. But I think with the DDE type approach, it's not going to require, in particular, smaller practices to adopt, but rather give the option. And so if you can support it, you're permitted to without having to go through, a CMS exception process. I think with that, in fact, I think we'll skip this slide, Michael. I think we'll go to the next one. Because I want to talk a little bit, we're running out of time here. So I want to talk about reporting metrics. In particular, we want to hear if there are any concerns with what CMS is opposing. So obviously, they've got a long laundry list of things that the impacted plans would be required. So anything on the list that you would like WEDI to say we're concerned about, or it should be off the list, anything before we move forward? Not seeing any hands. Let me just check the chat. Good, and there's a couple of folks, Pam says, agree on the option rather than require. Yeah, good. And Janice supporting both. Yeah, good, okay. One more. Yeah, first reporting due 3/31/26. Of course, that's the proposal. We'll see if that ends up in the final rule. Okay, good. Okay, Michael, I think we can go to the next slide. The next one as well. I think we've gone through that. So let's just do a quick poll. Level of support for the proposed metrics to be reported by impacted payers. Again, it's a long laundry list that would have to be publicly reported. So few unsure. Looked like the general level of support for the proposal. Okay, I think that's good, Michael. I think we can move to the next slide. Format, yeah, let's skip this one and move on. I think, so gold carding. We're all familiar with gold carding, essentially exempting certain providers from prior authorization. So they are looking at ways to encourage gold carding, and they are proposing including a gold carding measure as a factor in quality ratings for MA organizations and qualified health plans. Janice, you got a comment on this?
Yeah, my one comment on this, I won't take long, I promise, is that it would be nice to have more than there's the ability to do gold carding. They need to expand more on what they feel is and is not appropriate in this area within the rule. Is at least that's my feeling. They basically just say, you know, gold carding is allowed, and they don't supply any structure or requirements or guidance or anything around how that would happen.
Gotcha. Yeah, good point. Ed?
So, sorry there, Rob. We've talked about this in the prior auth sub-work group, and I know a number of people feel this is a wonderful approach to reducing the number of prior auths. I just hear from both providers and payers that how it's being currently administered on either side has been, I would say, stressful or a burden. And I just kind of put that out there to see if anyone would like to comment on that topic.
Bob, please.
Yeah, we recognize that gold carding may be one of the things that exempts a provider from needing to do prior authorizations. And within the implementation guides, we have the ability to recognize that as a response that we can give back to a provider that you do not need to do prior authorization for this because you are gold carding.
Excellent. All right, Michael, I think we can go to the next slide. You've got a poll, and it is, should WEDI encourage CMS to develop future policy to expand the use of gold carding? I don't know, Michael, if you could pull up the poll.
In a sec, Rob, having some kind of problem
Okay.
launching it. Hold on, give me a sec.
There we go. Thank you very much. So again, should we encourage CMS to develop future policy to expand the use of gold carding? And there's obviously a lot of issues. But one of the most challenging things is making sure that the provider profile is updated on a regular basis. So they may be eligible for gold carding today, but not tomorrow. And it has to be fair, between providers. So it looks like a little bit of a split. Got majority saying yes, but significant number saying no. And of course, as Mike says, yeah, the government plan should lead by example, and there have been some efforts on the part of government plans to do gold carding, so that might be a part of
Hey, Ed, we might be having some technical difficulties with Rob's audio.
Okay, let me let me take over that. So the gold carding survey kind of came back and it looks like 40% said yes, 19% said no, 20%, 26 unsure, 13% no opinion. Let's go to the next slide, Michael. And I apologize, my dog has a new toy, so he's squeaking. So if you hear that, that's Peanut. So can you go next slide?
Next slide's up with a new poll.
Oh, goodness. Okay. Should WEDI encourage CMS to incorporate a gold carding measure into star ratings? Okay, here's the new one. So please answer that one. And results are coming in. And kind of mostly no, with next percentage being unsure at 32%.
Thank you, Ed. I apologize. I got kicked off. But, back now. So good. Looks like
You're ready for the next one.
We're on poll number 10, Rob.
okay, good. It looks like pretty significant numbers saying no or unsure. So that's good guidance for us. So I think we can go to the next slide. Okay, so I'm going to lump this in with our discussion that Rebecca raised earlier, and that is we have, unless we hear from providers in particular, Celine, if the AMA, for example, is opposed to including this measure in the MIPS program, I'd like to hear from you on this. But obviously not all providers are covered under this promoting interoperability program. So we'll start with Celine, but I want folks to think about how we can encourage and incentivize those providers that are not participating. How can we encourage them to support the technology? Celine?
Hey, Rob. Yeah, the AMA is definitely going to be commenting on this piece. We are opposed to the idea of reporting the numerator and denominator. It's going to be very burdensome on providers and require, them to go into manual methods. If CMS really does want to move forward with this, our suggestion would be to do attestation rather than the numerator and denominator requirement.
Okay. Are there any other levers that the government has to incentivize providers? I'll turn to you again, Celine, if you don't mind. Anything that the AMA is going to be suggesting to the agency? How can we get providers to be engaged on this?
I mean, again, if we're able to prove that, are able to show through metrics and real world testing, that for the end user that this is going to be valuable to adopt, providers will adopt, what works. They want their burden to be reduced at the end of the day. So I think, really focusing on showcasing the readiness and scalability of the technology is one way to do that.
Okay, excellent. Other thoughts? Or we okay, we can go to the next. I think the next slide talks about next few talk about inpatient versus outpatient. We can skip ahead on that. Skip ahead. We'll go to the poll here. So do you support the proposal that a PARD API measure be included in the MIPS program? I'll say both for inpatient and outpatient providers. And again, the challenge is, how can we incentivize providers to adopt the technology? That looks like the yeses are winning out here a little bit. but significant number unsure and no opinion. Okay, I think we can end the poll.
Yeah,
Appreciate
Rob,
that.
Rob, this is Stanley, just in terms
Yep.
of incentives. You know, the difficulty here is that these requirements are only applicable to a certain set of health plans and not all health plans. It makes it a little difficult for providers to say, oh, all right, this is a Medicare patient. I've got to go through this prior authorization and use these particular methods for prior authorization, and I get it back in 7 days, as opposed to dealing with their commercial health plans, and they go through a completely different process. So one of the issues will be trying to expand this as much as possible to the commercial side so that it's easier for providers and it's a more natural part of the workflow for all patients rather than just some patients.
Exactly. And Ed, before I go to you, Michael, if you can skip ahead, because we do have a slide on that. One more. There. So go ahead, and I want folks to think about how we can incentivize providers and commercial health plans to support. Ed, please.
Yeah, this is on the previous topic, the build it and will they come was a real concern on the 2020 rule. And this time, they actually went with the MIPS providers. And when we talked to Alex Muggy, her perspective was that by at least those within her control of her program, she can get those providers to use Party or PARD. If we can go ahead and get them to actually EMR system actually add that to their systems, then it would be there for also non-PARD type providers or non-MIPS providers, and also would be able to bring people to the commercial world. So I just thought that was an interesting perspective by Alex.
Yeah, excellent. So we'll go Celine and then Janice, and I think we'll stop there. So Celine, please.
Yeah, and on the incentivization note, from our perspective, if CMS shortens the timeframes to final decision, that will incentivize providers. So that's a big push for us as well. Just wanted to mention.
Yeah, good point. Janice?
Yeah, I mean, I would just add to what Ed said, that CMS's approach generally is an expectation that this is a floor, not a ceiling. And by requiring any of these rules for those plans that they do, that the hope is that everyone will adopt them. And we found that that was very mixed with the May 2020 rule. But I think that with prior authorization, there is some incentive of being able to do it the same way for everyone, because this is a process that you're going to have to do for all of your plans and all of your payers. And so I think there's also that added lever with the patient access API or the provider directory APIs or things like that. There was no, there wasn't a requirement to do that in some other way for the people you weren't doing it via the CMS way. So I think that's an added incentive, because doing it all the same way for everyone is just makes it easier and reduces the burden, et cetera, et cetera, et cetera.
Excellent. And the one thing that strikes me, I have it down here on the slide, and that is for potentially even WEDI to establish the return on investment for both sides, for the payer and the provider, and really shine a bright light on those payers and providers that are taking advantage of this approach, and that itself might serve as an incentive for others to adopt. So with that, we have come to the end of this long and arduous road, and I wanted to, skip ahead, Michael, if you don't mind, to the one more there. I wanted to remind you that the fun is not over. There is another session specifically on the attachments proposed rule on Thursday. It'll be, we promise it'll be just as fun as this. And I want to just take a minute to thank a few folks. I wanted to thank Ed, Bob, Derwin, and Stanley for their excellent facilitation. And I wanted to thank all of you for sharing your thoughts and comments. This is a very important rule. What WEDI says is important. So what you have helped us with is invaluable. I also wanted to thank our expert, Michael McNutt, for making things run smoothly, for unmuting folks in a timely manner, and for pulling it all together. So with that, I will end the call and look forward to seeing at least most of you on Thursday, 1 p.m. My last pitch, it is critical that you fill out our survey. So please go to the link that Michael put in the chat. If you can put in the chat again, Sam or Michael, if you can throw the link in there again, please fill out the survey. It is very helpful for WEDI and helpful for CMS to hear from the industry. So with that, thank you all, and look forward to another spirited conversation on Thursday. Take care now.